Hi, this is Alan Gassman. It's hard to believe it's already Wednesday, March 25th, and I am so pleased to be here with my friend, colleague, and mentor, Lester Perling. Lester is a very experienced healthcare lawyer, former hospital CEO, and superhero. Lester's been giving a lot of thought and a lot of advice to what medical practices are going through and what they should and shouldn't do, and is generous enough today to be here to share his wisdom. Welcome, Lester.
Good afternoon, everyone. I hope everyone is doing well in these very difficult times. Alan is right that the current situation poses a lot of challenges for healthcare providers in all kinds of settings. The most obvious one would be, of course, in hospitals, but physicians' offices have their own challenges that are very unique to this situation and really unprecedented, at least in any of our lifetimes. So this requires a whole lot of creativity, both on the part of the practice and also on the part of the government to support medical practices and keeping patients well as much as possible during this time, because clearly patients still have a whole variety of healthcare needs unrelated to the coronavirus that somehow physicians still have to manage. And that's what we're going to talk about today in large part. So, I've talked to a number of medical practices that have a lot of unique solutions, some of which are quite creative, some of which are potentially problematic. And unfortunately, a lot of the answers to their question, can I do this, can I do that, or can I do the other thing, is not so much a legal answer, and sometimes it's almost more of a common sense answer. A good example, and a question I've had 3 times now, kind of surprises me because I haven't thought of it prior to this, is can I make patients wait in the car until it's time for their appointment, which seems like a reasonable thing to do on its face, but there's some potential problems with that. For example, I know in South Florida, at the end of this week, it's been 90 degrees. And depending upon how long that wait time is, particularly an elderly patient or an infant or someone who has some comorbid conditions, sitting in a hot car for, in one case, one practice told me, up to 2 hours is probably not a reasonable solution. And the question that the practices are asking is, well, what if something happens unrelated to the heat? But let's say someone's waiting in the car and coincidentally has an MI or has a seizure or something. Am I going to be liable? And those questions are great questions that we really can't answer at this point. I mean, it's clearly if something bad happens to a patient while they're waiting, for example, in a car, a plaintiff's lawyer is going to probably attempt to take advantage of that at some point. And so then it's going to come down to what unique defenses are available and some degree of reasonableness. I'm not that comfortable with the car waiting idea unless it's a very limited amount of time. But that's an example of some of the creative solutions that medical practices are coming up with to try to avoid patients coming into the office. But there are probably some better ones. So one of the more significant ones is treating patients remotely in various ways. And Centers for Medicare and Medicaid Services has recently addressed that by relaxing several guidelines that it has that limit the use of various forms of remote medicine, telemedicine, and other remote visits. And we're going to talk about that now because that's probably the better idea than making patients wait in cars, although some patients obviously need some sort of physical examination. So heretofore, most remote healthcare services, at least provided to Medicare beneficiaries, have to occur in limited facilities. They have to be generally in rural areas or other underserved areas. So the key change now is that these services can be provided to any Medicare beneficiary in any location. And so the patient doesn't have to be in a nursing home or a hospital. Patient doesn't have to be in a rural area. So that's a really important change, and one that medical practices should take advantage of. So this slide has a lot in it. We'll cover some of it. So this all began effective March 6th. So for those of you who have, even before Medicare announced these changes, rendered telemedicine services after March 6th that otherwise may not have been covered, you will be able to bill for those services to Medicare beneficiaries. A lot of health plans also have limitations on telehealth services, of course, and they vary plan by plan. Many of those health plans are also loosening up their limitations to allow reimbursement for telehealth in more circumstances. And so to the extent you're a member, not a member, but rather a participant or provider in a plan, you would need to check with each of those plans in terms of what's going to be covered. And of course, services can be provided whether they're covered or not. If you need to see a patient and you can't bring them in and you want to use telemedicine, even obviously you can do it and may or may not get paid for it. So in terms of doing telemedicine, you can do common office visits, mental health counseling, preventive health screening, most of the things that you would do in the office. Obviously, you can't take a blood pressure unless the patient happens to have remote equipment. You can't do a physical exam unless someone's there with the patient that can report to the physician. But there's a lot of things that you can do. Again, as I mentioned, the requirement that the patient be in a rural area or in certain types of facilities is being waived. These visits are billable as of March 6th, and they're for telehealth visits. They're considered the same as an in-person visit. So you would be billing the same CPT codes that you would bill if the patient was in the office. The visits can be performed by doctors, physicians, nurse practitioners. The slide doesn't say it, but physician assistants, clinical psychologists, and licensed clinical social workers. Now, I should mention that what I'm talking about now in terms of what we're calling telehealth is a video image, video connection like we're doing here. It's not a telephone visit or some other type of visit, but we will be talking about those because those are actually going to be reimbursed as well, but we'll talk about those. The thing that allows this to, one of the things that allows this to happen is that the Office of Civil Rights is waiving some HIPAA requirements. And I think I have a slide on that after this, but that allows providers to use video connections like Skype or FaceTime that they may not have been able to use before because they were not HIPAA compliant. And so more patients would have access theoretically to those types of video connections than they would a secure connection that would typically be required. Their Office of Inspector General is providing some flexibility for these visits in terms of waiving cost share or co-payments. And to the extent that a previously existing waiver may have required an established relationship under OIG safe harbors, the OIG is not going to require that in this situation. So, you know, the government fortunately is recognizing the unique aspects of the situation, and really as a practical and common sense matter, you know, each practice has to do the same thing and try to figure out what works, even if it's unique, even if it's creative, so long as it's not flat out illegal. So these are the CPT codes that can be used for these types of telehealth visits according to CMS. Now, one point I want to make with regard to being creative in doing things that at least are not illegal is, you know, you can't throw all caution out the window. You know, services still need to be medically necessary. You're still going to have potential liability for professional liability occurrences. So, you know, you need to keep in mind that there's still some basic requirements that are not just being thrown out as a result of this public health emergency. But, you know, even if it's within reason, so long as it's within reason, I guess is the better way to put it, you're probably better, you're probably better off asking for forgiveness rather than permission in these situations. Again, so long as it makes some sort of common sense. So this is the next type of remote visit that Medicare has loosened up on, and this is a virtual check-in, that something many of you may not have even heard of up to this point. And this can be a telephone visit. This does not require a video connection. Now, these are limited, and as the slide points out, these are really just for quick visits. The patient needs to agree to do it in advance. However, practitioners can inform beneficiaries of the availability of this type of visit. And as I mentioned, can use telephonic services. So for patients who don't have video capabilities, this may be another option. Now note that these have to be established patients. The services are limited. This can only be a discussion, obviously, if it's going to be by telephone, but there are billable codes that are on this slide. So I got a question from a provider, a large practice with lots of offices that is very heavily into Medicare Advantage. If you're a medical practice that does a lot of Medicare Advantage, you're familiar with HEDIS requirements. And one of the things you don't want to do is have gaps in care, because if you have a gap in care, your score goes down. That can affect your overall reimbursement going forward in the future based on meeting quality standards. So this provider was concerned because, as a practical matter, and something you may be thinking of as well, a lot of particularly elderly patients and low-income patients may not have access to any video service. They've not even FaceTime or Skype. They may not have a smartphone, and they have a flip phone. And even if they have a smartphone, they couldn't get into a video conference to save their lives, literally. And so these virtual check-ins may be another alternative. The problem is these may not be recognized and aren't recognized by Medicare Advantage as a patient visit in typical times. And if a patient's supposed to come in for a visit and doesn't and misses that visit, and you do a virtual check-in instead, which is a telephonic check-in, in typical times, again, Medicare Advantage plans may not recognize that as a visit, and it could lower your score. And if you bill it as a visit, could potentially even lead to some fraud issues. So getting back to this client of mine, they asked, well, where patients just don't have access to video, and I pointed out, well, even if they don't have it on their phones, their neighbor may, their children may, their grandchildren may, and if they can get access to it in a safe way, considering the requirements of social distancing, that would be a better alternative. But if telephone is the only way it can be done, and there's no other way to actually deal with the patient, then I would do this, and I would document it carefully. I would document that it was a telephonic visit, why it had to be conducted as a telephonic visit. Obviously, document as well as you would any other visit, which is true also for a video telehealth visit as well. Under Florida law, you have to keep a medical record the same as you would any other visit, and those requirements are not made, although are not waived rather, although the Florida Department of Health and the governor are encouraging physicians to expand their use, obviously, of telemedicine in these trying times. But again, for where this is the only possible way to do it, I would do it, even if it's not something that's billable, even if a third-party payer won't pay it, but the patient needs some sort of follow-up in order to avoid abandoning a patient, in order to avoid complications. This is better than nothing. And so for some patients, this may be the best option.
Lester, the second one there seems to be reviewing a pre-recorded video. It says remote evaluation of a recorded video or images submitted by the patient. So maybe a medical assistant would interview the patient on video and then the doctor would review that interview and
Well, if
be
the
able to bill
patient,
for
yeah, I
that?
mean, well, for this perhaps, I mean, but if the patient has access to video in real time to speak to a medical assistant, then I question why they wouldn't be able, the physician would not be able to do that and make it a true telehealth visit. Because, you know, here the issue is, one, they don't have access to it, or two, they may have access to it, but not when they can access their physician. So, and you'll note that this talks about recorded video and or images. I'm not so sure it really relates to an interview of a patient, but it could. But again, if a nursing assistant or a nurse can do it, why not have the doctor do it and bill for the telehealth visit, which would be or a nurse practitioner or a physician assistant, which would theoretically be a more meaningful visit than just having the nursing assistant interview the patient. But again, these are unusual times, so the doctor may be spread thin because they're treating patients in the hospital or otherwise very busy, depending on their specialty, and they need that kind of support. In other specialties, the doctor is going to find they're twiddling their thumbs because of something we'll talk about later, which is postponement of non-urgent care in certain situations. So it's going to vary by practice. But again, Alan, you kind of do what you can do, the best you can do, and the best you can figure out for your practice, and make sure you document it. You may or may not be able to bill for it or get paid for it, although you could try and see what happens. But the primary point is taking care of the patients that need some sort of care and some sort of follow-up.
Lester, do you have any idea of what a doctor would normally get paid for a physical encounter versus a video encounter versus a telephone encounter?
The video encounter and the in-person will be exactly the same. They will treat the video encounter as in person. For the virtual check-in, which is the telephone encounter, I do not know what the payment would be. It's not going to be much, I can assure you, but because even an in-person visit isn't all that much, but this will certainly be less, but I don't know what it is.
Do you think there will be any federal legislation to require insurance carriers to make the same payments?
Well, that could be tough because the feds have limited regulatory authority over a lot of insurance plans. CMS certainly has authority over Medicare Advantage plans, and I know CMS is working with them to broaden what they will cover and limitations. And generally, the Medicare Advantage plans follow the payment policies, not the amounts, but the payment policies of Medicare itself. So if Medicare allows virtual check-ins under certain circumstances, the Medicare Advantage plans would allow it as well. What they'll pay for it, of course, and whether it's actually going to be covered is a different story. Congress, for a typical health plan, those can only be regulated by the state. And I know states, including Florida, are looking at their insurance regulations and what needs to be done to loosen up the ability to provide creative care. But that's unfortunately going to be a state-by-state kind of activity to a large degree, as opposed to federal. Federal can control CHIPAA and certain other federal healthcare programs, including Medicaid to some degree, because the feds can require the states to do certain things in order to continue to receive federal Medicaid share of funds. But for truly private insurance, there's some more challenges.
So they can definitely be paid by Medicare for these video and these telephone calls if they follow the code requirements. Most likely they'll be paid by HMOs, also known as Advantage plans, but we're not absolutely sure yet. And then most likely they'll be paid for this by TRICARE, which is the military, and CHIPAA, most likely. And until insurance carriers actually agree to this, or it's already in the plan, or the state law changes, they probably won't be paid for these things by private pay. Does that summarize it reasonably?
It depends. Yeah, I think so. It depends on their, the private payers' existing policies. Look, if you're providing one of these services and you're not sure if a given plan or third-party payer is going to pay it, document it and appropriately and send in a claim, and see what happens. And it may be denied initially, but perhaps the plan will change its policy later and you'd be able to resubmit the claim. So, it doesn't hurt to try when you're not sure what they'll pay for. The worst that will happen will be that the claim will get denied. But again, if you don't submit the claim, you obviously will certainly not get paid. And so I would submit the claim.
Okay. Now, you're absolutely sure that there's no problem at this time using Skype or FaceTime or anything else for the video conference between the doctor or his staff and the patient? No issues with electronic medical record rules or privacy rules on the federal level at this
Correct,
time,
because
right?
that's governed by HIPAA and that has been waived temporarily.
Okay, beautiful.
Correct.
Okay, thank you very much.
Absolutely. Then the final sort of remote visit is an e-visit, and an e-visit is a email, just like it sounds, or it could be through a patient portal if the medical practice has a patient portal that can allow either email exchanges, or some patient portals even allow real-time email exchanges, almost like texting. And so that's the third type of service that can be provided. Again, it's no longer limited to any specific area. Again, these services need to be initiated by the patient, but practitioners can inform patients that this type of service is available. And again, it's a payable service, at least by Medicare, and probably by Medicare Advantage plans to the extent you're fee for service as opposed to a risk contract. And again, payer by payer, we'll have to see. But, and this would be for, I guess, the three types of remote visits we just talked about, probably go in hierarchy to some degree of acuity as well, in terms of the type of patient that you may feel comfortable treating using a telehealth video visit versus a telephone visit versus just an email exchange. And it also depends, of course, on the capability of the patient. If a patient can do an email, they can probably also do a telephone. But nonetheless, it's another option that medical practices have. And here are the codes to use to bill for those services. Keep in mind that while these are extraordinary times, and the CMS and the OIG and the OCR and other federal agencies, the Department of Health, are loosening up on requirements, that doesn't mean that they're not going to be watching later to ensure that there's not fraudulent activity that's occurred, because this does open the door for fraud. And while there may not be a lot of real-time enforcement, I would imagine when this emergency is over, hopefully sooner rather than later, they're going to be doing some data mining and looking at practitioners, providers, and others who may have taken advantage of the situation, much like hoarding toilet paper, which I'm still trying to figure out myself, but that will always be a mystery. So anyway, keep that in mind. This isn't like an open door just to do whatever you want, whenever you want, and send a claim and not worry about documenting it. There's still, like I mentioned before, there needs to be some guidance, common sense, and some prudence that guides you in recognizing that, you're still subject to audit later on, if you look like you might be taking advantage, if your data really looks strange. So keep that in mind. These are some codes for non-physicians. So the codes I just put up would be for practitioners. These would be for codes for type providers that normally wouldn't be able to do this, like physical therapists, occupational therapists. So a patient's on a home program, for example, and emails the therapist for instructions or some sort of assessment or whatever, as you can see, there are codes that allow those individuals to bill for those services that under prior rules, obviously they couldn't even do them, much less get paid for them. Again, you know, if you're a physical therapist and you're listening, you got to keep in mind that while Medicare might say, okay, great, you can do this and we will pay you under these codes, you still have to comply with Florida law. And if Florida law requires that you do an assessment in person, then you may still have to do that assessment in person. Now, granted, I feel confident just from my many years of experience that the Department of Health and the various professional boards are not going to be going after therapists who, again, use creative methods to continue to care for patients that can't be cared for in traditional ways. So again, it comes down to, as long as you're prudent, as long as you're using common sense, as long as you're documenting what you're doing, you're not taking advantage of it. You know, I wouldn't worry, I wouldn't be overly concerned about defending those cases, even if they do come after a therapist, but I don't think they will. Again, everyone understands the situation, you know, unless someone clearly is taking advantage of it, clearly using these types of creative treatment methods in inappropriate ways, whether it's for financial gain or for ways that could, you know, prove harmful to patients. And I think most
Lester,
professionals.
you've mentioned Florida law. Any other laws come to mind of other states, or most of the states are consistent in this area?
States are, I mean, I think the states, I mean, I haven't done a state survey. Obviously, every state is looking at the same issues. Some states may be ahead of others in providing waivers more formally. So yeah, every state is I'm very comfortable without doing a survey, you know, going through the same processes. But again, a lot of it is just going to be more through selective enforcement, probably, than like the OIG has even said in certain circumstances, than necessarily passing rules, etc. Now, Florida has passed some, and that's a good segue, Alan. So Florida, for example, is loosening up the ability of practitioners in another jurisdiction to provide telehealth visits in Florida. So there's a relatively new law, it's just about a year old now, that allows practitioners in other states to provide telehealth services in Florida when they're not licensed in Florida, but they have to register here. And there's a little bit of a process they have to go through. So that registration process is being waived so long as they're actively and licensed in the state in which they practice, and they have a clear unrestricted license. So if they're on probation or some sort of supervision, they couldn't do this. So it just basically waives that registration process and allows, again, some more creativity and flexibility for treating individuals in Florida. Another particular state waiver relates to controlled substance prescribing. So those practitioners who are listed by the Department of Health and have designated themselves as controlled substance prescribing practitioners can now renew a prescription for a controlled substance through the use for the treatment of chronic non-malignant pain without conducting a face-to-face as required by Florida statute. Currently, it can be conducted by telehealth. And note, this is an interesting point that sort of goes to what we're talking about, that not everything that the feds do will necessarily apply in a given state that has a more restrictive law. So the DEA is actually permitting the use of telemedicine for new prescriptions of controlled substances. Florida has not gone that far. So despite the fact that DEA has loosened up for even a new controlled substance prescription, at least up to this point, Florida hasn't gone quite that far. It's only for renewals at this point. So that's a good example of, you may read something about like this, that the DEA or some other federal agency has loosened up some statute or reg or requirement, and you go, oh great, I can now do this with impunity, and you don't think about state law, which might still prohibit it. You know, it may be something that in a given situation, you may go ahead and say, look, I need to do this and I'm going to do it, and I'm going to document the reason that I'm doing it, and I'll deal with the consequences later if there are any, and that might be the prudent thing to do in certain circumstances. You know, be careful though with controlled substance prescribing. You know, it can still, again, you know, enforcement in that area is not going to go away. And if they see a physician's prescriptions have spiked during this period, you know, at some point after it's over, somebody may take a look. So, you know, again, don't use this as a get out of jail free card entirely, because you may be doing that at your own peril. So CMS issued some guidelines, some recommendations really regarding limitations on elective surgeries and procedures. And they sort of provide these bullet pointed types of issues to consider in whether or not you can go forward with a procedure or surgery. And then they provided these tiers that provide more definition of what they consider to be something that you should almost certainly postpone versus maybe postpone versus don't postpone. And you'll notice these are about procedures and surgeries, not necessarily just patient visits. Florida has now, through a executive order by the governor, essentially formally adopted these CMS recommendations. And the executive order, though, talks about that these don't apply when you don't have to use personal protective devices. So, for example, a dermatologist can do a procedure that doesn't require the use of a mask or gloves. You know, it's using a laser or something where they may not wear gloves and don't have to wear a mask or don't have to wear goggles. Then these limitations don't apply. And again, it's at the discretion of the physician and common sense in terms of whether or not they really want to be, you know, getting close to a patient for those types of elective things, keeping in mind they can't do it if they would rather wear a face mask, then it would fall within probably one of these categories that should be postponed. Mental health visits are another one that can be done because they don't require protective gear and shouldn't be used. But again, those potentially can be done using telehealth or telephonic visit, et cetera. So that again goes to the preference really of the practitioner. There's nothing that says practitioners can't have patients come to their office. They shouldn't have more than 10 patients in their waiting room at a time. I question whether, you know, that's really a good idea or not. But again, that's a practice by practice sort of decision to make, and whether they can use that 6-foot guidance between patients, which I read an article this morning by an epidemiologist who says that 6-foot limitation was made up out of thin air, and he believes, in fact, the virus can travel further than that if somebody sneezes. So, you know, there's a lot of unknowns and a lot of probably a lot of guidance that may or may not be based in good science, which, you know, whether or not a physician would be liable if a patient could demonstrate they caught the virus while sitting in their waiting room, who knows? I don't know. You know, I bet there'll be lawsuits about it down the road. But obviously the physician can't know that if someone's not symptomatic. So, so again, it's common sense. It's what you're comfortable with yourself as a physician, what you're comfortable exposing your staff to potentially in terms of what patients you see and what you don't. If it were me, I would keep patients out of my office and use all of the remote types of visits that are available to me, unless it was just really critical to see a patient. So for some reason or another, you know, and again, that's a case-by-case decision.
Lester, I can't thank you enough for your wisdom, your dedication, and your putting up with me over the last 20 years. Let's hope there's another 20, but that this virus doesn't last more than another 20 days. Thank you.